Good afternoon, everyone, and welcome to Grand Rounds today, the 4th of November. I've just been having a little chat before everyone arrived, and it reminds me of the intro to a joke. What do you get if you take an Englishman, a Welshwoman, and a Canadian walking to Grand Rounds? Well, you're about to find out. So I'm Tom Ford, and I'm the chair of Grand Rounds, and it is a truly international meeting today, as our speaker Lynn Ashdown is in Ottawa, and even more excitingly, Linda Jones is in Broughty Ferry. So thanks to the marvel of Zoom, we can continue with Grand Rounds. So I'm not going to say much here. I'm going to hand straight over to Linda Jones from our Centre for Medical Education here in the University of Dundee, who's going to introduce our speaker, Lynn Ashdown, who is a candidate for the Masters of Medical Education, who's going to talk about her personal experiences and how they relate to the patient journey. So Linda, I'll hand over to you now. The only thing to add, please do mute your microphone unless you're speaking. And if you have any questions, then please put them in the chat, although Lynn has left some time at the end for vibrant discourse and discussion, but it is helpful if you put the questions in the chat so we can try and screen through them and plan things. So thanks very much. Over to Linda.
Thank you. Hiya, everybody. So Lynn, I think you have control of the slides. So basically, let me start by saying I know Lynn because I'm supervising her Masters in Medical Education. This first picture, so click please, Lynn. This first picture is of Lynn, I don't know how long ago, but I would think quite a few years ago, because she's a very sporting kind of person. And you can see this must be the hockey team or something.
A nod to my Canadian heritage. You have to be a mandatory hocky fan if you're a Canadian. So
absolutely. Next picture. But you can see she was also a high-performing athlete. So that's her hanging upside down there. Next picture, please, Lynn. So what you're looking at now is Lynn out and about and clearly a sort of outdoor kind of person. And next picture. But what we're interested in today and why Lynn's here is because she's also a medic. So this is her working in a simulation lab when she was a student, and the last picture on this slide. And this is her graduating as a doctor. Next slides. This was Lynn a few years ago, and she will tell you all about that. Next picture.
Sorry.
That's all right. There you go. So Lynn is now a wheelchair user, but she's so much more than that, because what she has done is made use of that experience to consider and to advocate for the importance of patients as partners. I'm going to leave it to her to do most of that, but as you can see, she's a regular speaker at international conferences. And I'm so delighted to bring her here today. So this is what we want to achieve today. So basically, Lynn's going to tell you her story, but she's not just going to tell you her story. She's going to invite you to reflect on it, as either students, how are you learning, or if you're medical educators, then what are you teaching and how are you teaching it? So there's a note of challenge in our current thinking about patient-centered care and patient-centered medical education. I know Lynn quite well. I've known her for 3.5 years, I think now. So I know that she'll be advocating for patient partnership in medical education because she's so passionate about it. But the invitation to anybody watching this video, either live or afterwards, is to consider how you could enhance the value afforded to patient knowledge for yourselves. I've got just one more slide, and that's just to share some research that I did 20 years ago into the value of storytelling. So if you think of storytelling as being patient narratives, or they may be case studies, they may be all sorts of things. But why do we tell them? We tell stories. We tell stories, or maybe the patients could tell their stories. But what you see here is the outcome of my research. So it was looking at, it's these actual lived experiences of people who've experienced medical crises in some way, and inviting that reflection on the experience, not just having the experience, but reflecting on it and therefore learning from it. The stories themselves engage interest, and I can tell you, Lynn's story is interesting and for me inspirational. And then we've got this thing about when we're told stories, we can listen, we can engage, it becomes more positive. Oh, that's interesting, and therefore we engage and invest in our own learning. Now, there is space for disagreement and dialogue today, and it's often that story that will allow those differences to appear. And then, as you can see, you can add on concepts, ideas, information, because once we've told a story, we've all shared that story, we've got something in common, and we can then discuss whatever it is we're teaching or wanting to promote in the context of the story. And then last but not least, the posh word is verisimilitude or eureka, but I just think of it as, aha, that's what I could do. So without any more ado, I'm going to hand you over to Lynn, and she will tell you all about her journey as a medic, as a service user, patient, and as a medical educator. So Lynn, it's all yours.
Perfect. Thank you, Linda. So first off, I actually just want to say thank you and express my delight in being able to share with all of you today. As you may have seen, I'm coming to you remotely from Ottawa, Canada, so Canada's capital. And it's an absolute honor and a pleasure to be invited to your grand rounds. And I hope that you will leave here with some knowledge or even some thoughts for reflection for the future. So what I do is I do ask a lot of sort of rhetorical questions as we go throughout. And I believe, as Tom already mentioned, there will be time for sort of some questions and ideas and comments at the end. And so, if something really kind of throughout the talk really kind of stands out to you, you can make note of it. You can put it in the chat. Linda will be moderating the chat for me, but or you can just hold on to it until the end. But definitely we will have time to come back to everything. So 2 things that I want you to reflect upon first off, just to kind of get you all in. So we all have defining moments in our life. So I want you to think of one of those. It could be the day that you got married. It could be the day that you became a parent for the first time. It could be the day that, you received a poor medical diagnosis. It could be the death of a loved one. But we all, there are a few moments in our lives that really kind of change us. And so I want you to kind of think of, what that might be for you. And then, as you'll hear, I have a very in-depth experience with the medical system, but we all, even if it's to a minor degree, are a patient at some point, whether it's just for preventative care or, the delivery of a child or something like that. So we definitely do all have some sort of experience as a patient or a caregiver to a loved one who is ill. And so I want you to think of, a recent experience. Was it a good experience? Was it a bad experience? Was there anything that surprised you? So I just want you to kind of think of those 2 things. And so for me, the answer to both of those questions is actually they're the same thing. And so really, what this really kind of slide, alludes to is that, those defining moments in my experiences as a patient, my answer is the same. And that day was November the 27th, 2013. And my life, as you'll come to hear, changed in a heartbeat. And I mean that literally and figuratively. Every aspect of my life was completely altered, radically transformed. Nothing of my old life was left unscathed. And it left me with sort of this version of a Lynn that I call old Lynn and new Lynn, or my life, as sort of similar to the quote that I have here, is it is before and after that moment. So either my life as a physician and now it's a patient, or life before illness and life after illness. So now I bet you're wondering perhaps what this is that I'm talking about that happened on November 27th, 2013. So I'm going to try to paint a picture for you. And I was so I'm born and raised in Canada, as you know, and I've been fortunate. I did all of my medical training in Ottawa, Canada. And for many of you out there listening, I'm sure you know that sort of the medical training and residency can be a long path, and you often really don't see the light at the end of the tunnel. And but for me, I was actually just starting to see the light at the end of the tunnel. I had actually written my final family medicine licensing exam 3 weeks before we'll call it the date. So I'm referring to November the 27th. So 3 weeks prior to that, I had written my final and passed my family medicine licensing exam. Just had a few rotations left to complete for residency. So that light that I never saw before was just starting to peek through at the end. And so what happened on that day, my last memory was actually, I was doing an obstetrical rotation, and it was our first we get a lot of snow here in Canada, at least in certain parts. And so it was our first big snowfall of the season that despite the fact that we drive through snow 6 months out of the year here, somehow that first snowfall of the season still kind of seems to put the city in disarray. We somehow lose our ability over a 6-month period over summer to learn how to drive in the snow. So it was a big snowfall. I did make it to work on time. I remember parking my car. That's the last thing I remember. My next memory was waking up in the ICU, obviously being very, very confused, not knowing what had happened, how I had gotten there. From sort of what I've been able to gather is that I did actually, even though I don't remember going to work that day, I did go to work. And then I ended up at a coffee shop, and I was doing some studying, which is not uncommon for me. That sort of was my favorite place to study. And so what happened was, sort of witness reports were that I was sitting in a coffee shop on a stool, and I went into full cardiac arrest. And that was caused by a congenital electrical abnormality in my heart that I didn't know that I had. And so it's called congenital long QT syndrome. And so that lifeless fall from the stool caused me to sustain very catastrophic injuries. So a moderate traumatic brain injury, and sort of many open comminuted skull and orbit fractures, in addition to a fracture of my C3 and a spinal cord injury. Stemming from that are multiple diagnoses, so many of which I won't tell you about, simply because it would take the rest of rounds to tell you about. So I will, you can, with some sort of medical knowledge, you can kind of appreciate the depth and the medical issues that would ensue from that sort of I call that lifeless fall. And so, but what that did result in was you know, I spent 2.5 years after that accident straight as an inpatient alone. And then, you know, even after that, I obviously have very, very complex, multiple and complex medical issues, all of which influence everything else. So even though I am not an inpatient at this moment, I'm still very much an active patient, and I actually do refer to myself as a full-time patient. Some people find that a bit weird that I refer to myself as that. I'm not defining myself as that, but I use that term to reflect the complexity and the intensity and the immersion that I have as a patient for the last 7 years, sort of navigating the healthcare system. And I mean, my patient experiences are so wide ranging. I can't think of a specialty that hasn't seen me. I can't think of any part of any hospital in Ottawa. I mean, other than the fact that I trained there, but just as a patient, I've experienced every system in Ottawa. So all that to say, I do have a lot of experience, and I always will, actually, because most of my diagnoses, they will not sort of, they won't go away. So in fact, they'll continue to worsen. So I've really experienced it all as a patient, and I observed a few things though over the years. And so I call these my defining moments. And this was sort of what led me to meeting Linda and working on my my dissertation for my master's in medical education. It's taken me quite a few years because of the traumatic brain injury, but these defining moments were, I was shocked at how little my knowledge from medical training prepared me to be a patient. And then another one was, I learned so much more as a patient than I ever could have imagined. And I mean, so those first 2 points right there really had me thinking, well, there's a gap in something. How can I know so much yet know so little at the same time? And then the third point, medical education taught me about disease and illness, but my patient experience taught me what it meant to be ill. And those are two very different things. So it really reminds us, you know, medical education really taught me about more about biomedical knowledge, which is absolutely important, but I didn't have any idea how that impacts a patient's life or what that means to be ill, the impacts that it has on the patients, the families, the systems, all of these different things. And so that's really kind of what led me down this path to kind of say, okay, well, now that I've lived both of these worlds, how can I change it? So another question for you is, you know, for you to reflect on is, how do you currently teach or learn about patient-centered care? So a few questions to help you kind of guide you as you think of, as you ponder that question. One would be, would you consider patient-centered care to be foundational and fundamental to healthcare quality? So I hope that most of you out there, or if not all of you, would absolutely kind of look at that question and kind of say, well, yes. And the answer in the literature does support that. The answer is yes. You know, it shows to, you know, improve communication, increase health outcomes, increase patient satisfaction, shared decision-making, patient autonomy. I'll stop it at that. But, you know, it absolutely is fundamental to healthcare quality. Next question is, would you be surprised if I told you that it's commonplace to reference patient-centered care, but that clinicians actually lack an understanding of what it is and how to measure it? If I just in your head, you know, right now, if you tried to think of, if you had to explain what patient-centered care is to a colleague that maybe isn't in medicine, how would you describe it? But the answer to that question is that the evidence does show that we use the word patient-centered care a lot. It's referenced frequently in papers and sort of in clinical discourse in our medical education teachings, but that clinicians do actually lack an understanding of what it actually is, and also how do we measure it. If we're doing something that we think that is important to healthcare, how do we sort of measure it? Because, you know, spoken words does not equate into action. So as many times as we say patient-centered care, and I heard that a lot in my medical training, I actually kind of discovered through my journey as a patient that my compass may have been a little bit off on that one. And sort of the last question for reflection that I am actually going to return to in the end and sort of answer it a little bit further on is that, are we indeed practicing patient-centered medical education? So what I'm going to do at this point, so as Dr. Jones mentioned, part of my dissertation is to do an autoethnography. And so I guess the easiest way to explain it is that it's not really an autobiography, because an autobiography is just a chronicle of events. But what it is that it's a representation of my sort of knowledge as being a medical learner and being part of medical education, combining that with my lived experience as a patient, and actually taking those stories and actually turning it into learning, and then you can disseminate that information sort of on a broader, even though it's my patient journey, some of the themes can be applied at a greater level. And so so as I you know, present these three scenarios, what I'm actually going to do is I am going to show each of the scenarios to you. They'll be written on the screen, and I'm actually going to pause when that happens for you out there to read the scenario itself. I think it'll be more powerful for you to read the scenario. And it will also give me a chance to have a sip of water as well. But as you're reading each of these scenarios, and after each scenario, I just want to add that I will actually do some reflection and reaction after each one. But as you are reading the scenarios, I want you to keep in mind two things. As I present them, consider the value that patient narratives, such as the ones that I'm showing, but obviously not limited to mine, but to every patient narrative, the value that these narratives could bring to medical education. And also, could patient narratives offer us, and when I say us, I mean everybody listening, sort of anyone that's involved in medical education, access to knowledge not otherwise accessible in traditional medical training. And so with that, I'm actually going to show the first scenario, and I'll leave that for you guys to read. So I hope that I left enough time for everybody to read that. And so just in the interest of time, I'm going to now turn to sort of my reflection and reaction to that scenario. So one of the things was that instantly I could feel her compassion, almost as if you could touch compassion, it was there. And I started weeping right away. I wasn't weeping because I was in pain or anything like that. I was weeping because she got it. And this, 1,000-pound weight that I had been carrying on my shoulders for 15 months now was lifted, or at least it was lighter. And what it really felt like is that for the first time, I wasn't alone in this battle. There was someone there that actually truly got it and understood that there was more to Lynn, the patient in the bed, than just biomedical sort of treatment. There were many other areas of treatment as well. What she did was she saw me, she validated me, and she really freed me to express my true emotions for the very first time. Of course, I would have been suffering for the last 15 months. You don't go through a life-altering experience and come out of it on the other side saying, well, golly, that was fun. There absolutely is tremendous suffering that I had endured, but no one gave me the permission to actually say it. And I have, from my own experience and from going through, and when I say my own experience, sort of as a physician, and then my experience as patient, doctors typically are uncomfortable with uncomfortable situations. And we like everything to have a pretty bow and, to have follow a perfect algorithm and that sort of thing. But medicine, for the most part, patients don't read the textbooks, and care is individualized. And here was this doctor that was comfortable with the discomfort that came with my patient story. And so what this sort of scenario, and I called it the power of words, because it reminds us, the power of words, but that her words, those were in and of itself treatment. We think of treatment just from treatment from a biomedical perspective, but treatment is so much more than that. Just validating and freeing me to express my true emotions was in and of itself healing as well. And so, one of the things that this doctor had it, but I had been through 15 months of this journey, and no one else made me feel that way. So how can we teach that to everybody that is training to be a physician? So the next scenario, I'll give you a moment.
Lynn,
Yes.
I'm just going to let you know it's nearly 12:30, just so you can, know the timing.
Perfect. Thank you. And then so the second scenario, I'll let you take a moment to read that. So I hope that I've left enough time. It's hard to gauge when you can't see the audience whether people are done reading, but I hope that you've all had a chance to read that scenario. And so sort of, I think the first thing is that a moment like that stays with you forever. I lived that quite a few years ago, and every time I think about it, I still start to get emotional. And it really speaks to the vulnerability that patients experience when they're a patient. And so my reaction to that scenario, tears were streaming down my face because I laid there exposed, both physically and emotionally. In that moment, I had lost all dignity. I felt embarrassed, worthless, and helpless. I was dehumanized and disrespected when nobody made eye contact or even asked me for permission to examine me. And really the ultimate violation, if everything, not that everything else that had been done was okay, but the ultimate violation came when they turned around and left the room, leaving me exposed, and I was not able to do anything about that to cover myself back up. And so from that perspective, every action we make as a healthcare provider, there are consequences. What would have been the difference if, even if one resident on the way out realized, wait a minute, we just left her completely exposed here, and came back and actually covered me back up. The trauma and that in and of itself, even if everything else still kind of played out the way that I did, the fact that someone did acknowledge sort of and recognize the vulnerability I had been placed in, it would have changed a lot. And so the last scenario, and then we'll have chance for some comments after, is I'll let you read that one as well. So the first thing, before I go to the next slide about my reflection or reaction to this scenario, is when was the last time that any of you listening as adults, not as a child, but as adults, found yourself clinging incessantly to a stuffed animal? And so I want you to think of whether that even happened to you ever as an adult. Again, not referring to childhood, but this monkey that never left my side. So this actually is the monkey. This is a picture of me with the monkey. I kind of cropped myself out because the point of this, it's not about me, it's actually about the monkey that I still have here. So I thought I would show that to all of you. But really, being in a hospital puts you in this powerless, out of control position. And you're exhausted physically and emotionally, for me with my brain injury, cognitively. And I'll be honest that at times when I was clinging that monkey, I felt very juvenile. As like, well, before this, kids hold on to stuffed animals, not like a grown woman. But for whatever reason, I could not stop. But when I kind of reevaluate it in hindsight, that monkey represented something far greater than a stuffed animal. It represented something that I had full autonomy over. And there was no hospital administrator, no doctor, no nurse, anybody that had any say or control over that monkey except me. And I did not let anybody touch that monkey. And so I don't think it's juvenile. What it did was it was actually quite adaptive, and it allowed me to control something in an environment that is otherwise chaotic and uncontrollable. And and that's the environment that patients are dealing with when they're in a hospital. So 2 slides before we open it up to some questions and ideas. So the question is, I'm posing to you is, are we practicing patient-centered medical education? And so the answer that I'm going to give a very blunt answer, and I would say no. And now evidence does back me up on this, so I will sort of back it up a little bit more by saying that if you think about, our medical education, the primary focus is still centers around what the trainee needs to diagnose and treat the patients biomedically. And that's important because, ultimately we do want competent doctors that can treat patients, but, do patients have a say in how we train medical students to be, the best possible physicians in the future? They really don't. They are not at the center of medical education. And if they're involved, they're very much in the periphery. And really, we're not yet including patients' expertise. And I'm intentional when I use the word expertise, because I have learned from my experience that I garnered a whole extra area of expertise that, quite frankly, if I didn't ask for this extra area of expertise, but life kind of happens and you have to roll with it. But it really did, so I'm intentional when I use the word patient expertise. And so if we do even include the patient's voice, a question that I pose to you is, are they given the same weight? So, or is it, well, thanks for your input, but the doctor disagrees, so we're going to go with the doctor, so even if we do include patients, do they have the same weight? And so my final slide is a proposal for the future of medical education. Sounds simple. I know that it would be hard to do, but that doesn't, just because something's hard doesn't mean that it's not the right thing to do. So, but that would be to recognize and value the expertise that patients have. So this expertise is not in competition, and it should not replace the biomedical knowledge that we currently teach our learners, but it should be viewed as equal and complementary. And if this had been the case during my medical training, I probably wouldn't have realized, I wouldn't have seen those defining moments when I talk about that big gap that I experienced. That gap may have still been there a little bit, but it may not been as glaring and as deep. And so we really should put patients at the center of medical education. I mean, patients, ultimately, physicians are serving the communities of patients. And so, do we ask them what, they want to see out of their doctors? Because that really should be providing insight into educational priorities. And this also includes actively and meaningfully involving patients in all areas of medical education. So that includes, right down to the selection of medical students, curriculum development, teaching, assessment, feedback, governance, etc. And so with that, the formal, I guess, part of the presentation is complete, and I guess we will open it up to Linda is going to moderate the chat for me, but for people that have questions and comments, this is your chance.
Okay, everybody. So yeah, I will now monitor the chat. If there's anybody who has any questions for Lynn, I can see John Dowell, you've just made a comment. I wondered if you wanted, whilst people are thinking of what questions or ideas they want to post, do you want to say something about your experience?
Yeah, hi. Hi, Lynn. My name's John Dowell. I'm an academic GP, and thank you for sharing your very powerful story with us. I don't know if you have access to the chat yourself at your end.
Do.
And I was relaying a directly comparable experience I had as an undergraduate student in a specialist unit. And the message I wanted to support your message, I suppose, and I'm going to ask a question related to that in your closing point shortly, but also just to highlight, of course, that your discomfort may well have been shared by a number of those learners, and they may well have taken positively or important learning away from that time at albeit at your expense. So you can hope, I suppose, we'll never know. I certainly did, and my colleagues did, from that event that I was witness to, party to. The point I was going to make actually is I'm involved in setting up a new program that is heavily primary care driven, and at least we like to think significantly more patient-centered. I believe it is, but I think there is a cost to that in the sense of the time that you can spend on the more traditional factual based learning. And I don't know how we determine what the most appropriate balance is, because students who are more attuned to listening to patient stories, absorbing them, thinking about them, and being more patient-centered are often those who are a little less academically focused because they've reset their compass to a degree. So there is a trade-off, I believe, of some sort, and I'm interested if you had any thoughts about that or how that's judged.
Yeah, thanks, John, for your comment. First off, that for pointing out that the lessons may not have been lost on those that observed. So thank you for that. And I think that's the $1 million question in medical education is what's the trade-off, right? But I mean, patient partnership or active patient involvement in medical education, it doesn't necessarily, if you are giving a talk about spinal cord injuries, rather than just having the didactic, component of it, perhaps you could invite a patient to co-present with the physician or whoever is teaching about the sort of physiological, components of spinal cord injuries, but then sort of link that with a patient that has lived experience, because not only will that help to solidify, we all know that we remember a lot of our, early teachings in medical school when it's actually linked to a specific patient rather than just general material. But in terms of other ways about including sort of patients in medical education, it could be as simple as being in grand rounds and then, not grand rounds, but just rounding on patients and saying, actually actively including the patients and thinking of them as a member of the team. They're just as, equally important, have as much at stake, and I would argue have more at stake into what's happening than anybody else. But actually including them in the discussions, and areas like assessment and feedback. Could a patient be, during an OSCE situation or a standardized exam, would they be suited to be able to comment on, a medical learner's ability to be compassionate in the situation? Absolutely. They don't have to have a medical degree. I mean, especially patients with significant lived experience, they've received bad news in many different ways. They've seen it done well, they've experienced it done poorly. And so it doesn't have to necessarily come at a trade-off. It just requires us to kind of abandon the way that we think of our traditional learning model, and then kind of going outside of the box a little bit. I hope I've answered some part of the question.
Yeah, I think a lot of what you've highlighted is becoming increasingly common practice. Fundamentally, though, I do think there is a bit of a trade-off. I'm not against it. Clearly, I'm pretty pro it, but prioritizing or putting patients' perspective up the priority list does tend to knock some other things off, but learners love it. I mean, so it's an easy win in some ways, and we have to do it to rebalance. In Scotland, there's a thing called realistic medicine that our chief medical officer for a while previously was espousing and was trying to make this point, but there must be others who want to come in. So thank you.
And I'm not familiar completely with but the traditional, you've got your first 2 years where it's mostly didactic in the classroom, and then your last 2 years is sort of more clinical. Another way is that you're really only exposed to patients in sort of your third and fourth year of medicine, as you're out on the wards and doing your clinical teaching, but, introducing patients right from day one. So, that kind of teaches students how to do patient-centered care. So I think it gets rid of that that confusion when people think they're doing patient-centered care. It's that idea of partnering with and working with patients rather than just about or for patients. So even if it's not a trade-off, but let's just, rather than, you know, dividing the way we divide medicine even into biomedical, clinical, well, let's merge everything and sort of not make it also biomedical at the beginning. That's all. Thank you.
Thanks, John. Lynn, I just wanted to add something from another of our master's students, and that is that there's other ways to offer learners lived experiences. And I just want to share one idea, and then I'm going to just, I don't know, Tracy, whether you'd like to say something about your experience in a minute. But this was somebody who had very often in a long career suggested to somebody that they should wear a neck brace. He then hurt his own neck and was told to wear a neck brace, and managed to wear it for 20 minutes until he ripped it off and just abandoned it because it was one of the most uncomfortable things he'd ever experienced. And so we were sort of wondering about giving some people in an audience of a lecture a neck brace to wear for the whole hour, which might give them that lived experience of what the patient is being asked to do, to give, you know, to develop empathy. So that was just another idea from a different student who was also interested in patient narratives. But that difference of experience to understand what it's like for somebody else seems really key. And I think we're getting better at it here in the UK, and I suspect in Canada too.
So
yeah, go on then.
Linda, I just wanted to point out, and so although that's, you know, it gives an idea at least to how uncomfortable a neck brace, having been someone who spent about a year in something, immobilizing my neck, it gives a bit of an idea to how uncomfortable, but it still doesn't completely like deal with, well, like you can put it on for 20 minutes, but then try sleep with it, then try shower with it, then try fitting through a doorway with it, try dressing, and, you know, then adding in the sort of the emotional, the physical pain. Like, so absolutely, I'm not saying that it's wrong, and that it absolutely, if someone couldn't even keep it on for 20 minutes without having all of these other issues to navigate as well, it gives you, it's not an equivalent experience, but it, you know, may give you a small sort of snippet of an idea.
Yeah. And anybody else? Tracy, did you want to come in? Tracy's posted something about her own experience and an idea.
Yeah, just to say that I had cancer treatment last year, and my GP practice asked me if I wanted to go into the practice and speak to two trainee GPs about my experience. And I don't know how it was for them, but it was a very positive experience for me. And I don't know where along the journey they were. I'm not a medic, so I don't know about the training particularly, but you know, I don't know how integrated it was, but I just found it incredibly positive an experience. Yep.
Thanks, Tracy. And I think you've kind of hit on, and I sort of stay away from it in my dissertation, but I do sort of other patient engagement initiatives. And like it does come, it comes, there are some therapeutic benefits as well to the patients who do these things as well. Like an unexpected experience that I had from doing this dissertation is I actually did experience some therapeutic. It brought a little bit of closure and healing to that. So, you know, although I focused strictly on things from a medical education perspective, absolutely, it can be quite impactful and positive for the patients themselves as well. So thank you for doing that.
Thanks. We've got something from
Yeah.
a comment from somebody called TM Knight. Do you want to ask the question yourself? I don't know.
I can jump in.
See it. Okay.
Yeah,
Yeah.
so I'm seeing the question, and this is actually a topic that I'm quite familiar with, out of the scope of my dissertation, but just because of other things that I'm doing within Canada, it's a hot topic in terms of patient compensation. And so the answer is that sort of the rule of thumb is that you know, it should never cost patients. So if you're bringing a student in to talk to, you know, a class of medical students, then it should never cost them any money. At bare, you know, their parking should be paid for. If they require food, that sort of thing, it should never cost anybody anything. But in terms of compensation, like financial compensation above and beyond that, a typical question is that, are other people around the table being paid to do that job? So if other people, so the idea of patient engagement or patient partnerships or involving patients in all areas of healthcare is viewing them as equal stakeholders. And that despite the fact that patients have always been, I mean, patients are the reason we do healthcare. Without them, none of this would happen, but they've sort of been left out of the equation for far too long. But is sort of, if everyone else around the table is being paid to be there, then the patients, because if they're being valued as equal stakeholders, then they too should be financially compensated. There are ways to compensate patients, though, beyond financial. So, you know, it can be, you know, so I see in some cases, exactly like I was saying, like sort of vouchers could be given. It could be that they get entrance into, you know, into a medical, if they participated in a research trial, they can participate in the trial itself, and not the trial, but in the conference, and they get free admission to it. Or they might receive some sort of, you know, academic award from a university. So there are lots of things to think about when it comes to, you know, reimbursement, compensation, that sort of thing. And there, unfortunately, in Canada, and from what I've looked at internationally, there is no sort of right or wrong answer, but it really depends on also how much you're asking of the patient. If you're asking them to commit 10 hours a month for, you know, 2 years, well, they might, you know, that's a lot of time out of their schedule. And if they have to take time off work for that, then, you know, you probably should offer some compensation. But a lot of patients do it because they genuinely want to make a difference as well, the same way patients volunteer at a hospital. So I've seen a lot of patient partners get offered financial compensation, and they either decline it or they redirect it back to the hospital or something like that. So, but that's a really great question. And as patient engagement becomes more and more of a movement, and I've noticed that it has, just especially in the last sort of 2 to 3 years, it comes up more and more.
Thank you. So we've got a couple more comments. John's offered us a resource some people might want to see, and Fiona has, you know, wrote the point that you were just addressing. And I'm just going to say something a little bit more controversial, which is that we do sometimes we recompense people for their engagement in research. But I think what you're talking about today, Lynn, is patients' involvement in pedagogy and in scholarship, really, and having a voice in that. And I think we perhaps haven't given enough thought to that difference between research, valuing research, if people are engaged in that, and valuing scholarship. So go on.
Also, I was just, sorry, Linda, to interrupt. For those of you who don't know, with my brain injury, I don't retain short term. So if I don't answer right in that specific moment, I will lose my thought. So I'm not being rude, but there's a difference between, so when we think of patients being a trial participant versus patient-oriented research. So those are two kind of completely different. And so what I was referring to was patient-oriented research. And so that's where it's not just researchers that sort of create a clinical study and determine protocol and all that sort of stuff, but they actually have patient partners that are part of that design and implementation from the beginning. And they're different than patient participants within a trial.
Okay, so I'm aware of the time, and what I invite, thank you all for coming today, by the way, but can I invite people to sort of, you know, our aims today, one of them was to get you to think about in what small ways you might make use of anything that's come up through this session. So how might you include and empower patients to be part of medical education, not just to be a resource for medical education, but to be actually part of it? Is there some way? So if you know, if you've got any thoughts, do type them up. I don't know if anybody else has a last point to make before I hand this back to Lynn. But I would just want to say to you, I've known Lynn all of this time, and I've known how her brain injury has had impact on her work, and yet she's still about to submit a master's dissertation, which is, you know, it's a very cognitive skill. And I hope Lynn isn't going to mind you. Lynn, you mentioned that you parked your car on the last day you can remember. But one of the things that's happened is that you can no longer drive because of the impact on your decision making. So I really hope that people can recognize just what an achievement this has been.
Thank you, Linda, for saying that. I appreciate it.
Yeah, so you get the last word. You have 3 minutes left.
So I do see one question. Are there places where patients can be involved other than in classrooms? Absolutely. I mean, outside of medical education, I mean, at least in Canada, it's a requirement that all hospital organizations have patient engagement initiatives, but within the medical education setting, absolutely, they can be involved in curriculum design. They can offer feedback. They can be part of selection committees yeah, outside of the classroom. And there's even some programs, though few, but where the patients are actually, it's like a patients as mentors. And so students, you know, follow a patient with chronic long-term health issues over the period of their 4 years of medical school. And so the students actually learn from the patients in that situation. So there's so many ways outside of just the classrooms themselves.
And just one last thing, I know that Tom will post the recording of this, but simply showing this recording and passing it on to anybody you think might benefit from it, you know, it's a start, isn't it? So
and if anyone wants to reach out, my Dundee email, I think Tom will have, so he can you know, refer you to me or Linda as well. So I want to thank you all for just your attention and willingness to listen, and hopefully willingness to reflect as you leave today and go on with your afternoon. And I have my morning coffee.
Thanks very much, Lynn. We should appreciate the fact that it's what time is it in Canada right now?
Well, actually this week, because you guys had your time change last weekend, ours isn't until this weekend. So I'm only 4 hours behind this week. So it actually, if there was 1 week to do it, we didn't plan it this way, but it worked out great. So
definitely planned. Thank you so much for telling us your story and for your insights into the patient experience. Thank you to everyone who took part in the questions at the end there. I will do my usual bit of tinkering with the editing, and it will go up on our YouTube channel at some point. So if you like, subscribe, and click the wee bell, you'll get a notification of when the videos go live. Next week, it is the DCAT annual lecture. Professor of Medicine in Oxford, Professor Raj Thacker, will be talking about molecular genetics, and more information to come from the DCAT team, and I'll send that out next week. Okay, once again, thank you to Lynn, and thank you to Linda, and thank you to all. I'll see you again next week.
thank you.